Good morning, everyone. Welcome to the webinar entitled Blinded by the Lightest, an overview of methanol exposure and toxicity. We're excited to have you all here, and we're going to go ahead and get started. So we're going to go over a few housekeeping slides. If you're on your computer, you should see a questions box. So if you have any questions during the presentation, just put them in there, and then we will answer them at the end of the presentation. If you're on a mobile device or a tablet, you may not see this box, so you can send an email to me. It's boverall@georgiapoisoncenter.org, and we'll make sure those questions get answered as well. Everyone will receive a certificate of completion at the end of this webinar, as long as you fill out the survey at the end, and we'll provide that link at the end of the presentation as well. Certificates will be available a few weeks after you complete your evaluation. All right, and then the disclaimer: if you are a licensed nurse, you'll receive 1 contact hour for continuing education. You'll need to view the presentation entirely and complete the evaluation at the end to receive these credits. So now I'm going to go ahead and introduce you to our speaker. Dr. Filkins is a clinical toxicology fellow at the Georgia Poison Center. He received his Bachelor's of Science in Biochemistry from sunny Old Westbury and went on to complete his Doctorate of Pharmacy at the University of St. Joseph in Hartford, Connecticut. It was there that he discovered toxicology as a career path via one of the previous Georgia Poison Center fellows. Once bitten by the proverbial tox bug, he did everything in his power to become involved with toxicology throughout pharmacy school. After graduating pharmacy school, he was fortunate to be able to pursue his passion for toxicology by embarking on the 2-year clinical toxicology fellowship with the Georgia Poison Center. And after completing his PGY 1 year at Grady Hospital, he is now deep in all things toxicology. His areas of interest include venomous snakes, toxic alcohols, alcohol withdrawal, and cannabinoid hyperemesis syndrome. Not managing poison patients and reading classic toxicology literature, Patrick enjoys exploring local craft beer scene, long distance running, and spending time with his significant other and their beautiful 7-month-old English cream golden doodle, May. So Patrick, if you want to go ahead and get started.
All right, thanks, Brittany. Good morning, everyone. Thanks for joining in. So the title of this talk, as Brittany said, is Blinded by the Lightest. So an overview of methanol exposure and toxicity. The reason we're going to be speaking about methanol specifically today is, of course, in the current climate of the COVID pandemic. I'm sure everyone heard about the tainted hand sanitizers that have been recalled through the FDA. So I hope through this presentation we can talk about methanol exposure and a little bit on how to manage poison patients in general, but specifically those potentially poisoned by methanol. So the objectives of this presentation, we're going to assess the latest epidemiologic trends in methanol exposures, including historic mass exposures and then exposures that have happened as recently as this summer. We're going to identify the routes of exposure for methanol. There are several, so it's not just oral ingestions that we're concerned about. We're going to describe the pathophysiology of methanol toxicity, kind of how it affects your body and why it's very dangerous. And we're going to develop a treatment plan for a patient poisoned potentially by methanol. So alcohols in general are small organic hydrocarbon molecules with at least one OH group or hydroxyl group. Ethanol we commonly refer to as alcohol. However, ethanol specifically refers to the two-carbon molecule as pictured here that is consumed recreationally. And actually the production of ethanol is documented as far back as ancient Greek and Chinese civilizations. And even there's documentation of wine being produced in ancient Georgia since 6000 BC. So non-ethanol alcohols are commonly referred to as toxic alcohols, which is sort of a misnomer because all alcohols are toxic to different degrees. However, commonly toxic alcohols refer to the alcohols other than ethanol. And there are many of them with various uses, and again, all are toxic. I have a few of the common ones encountered pictured here. So we have ethylene glycol, which is also known as antifreeze. It's actually technically a glycol, which is still considered an alcohol, but it's a glycol due to its two OH groups. There's isopropanol, which is a common three-carbon alcohol, probably most often encountered as nail polish remover. You may find that in your local drugstore. We have propylene glycol, which our nurses, I'm sure, are probably familiar with. It's a common diluent in medications such as lorazepam or phenytoin, kind of giving it that viscous appearance. And then the subject of our talk today, methanol, the simplest alcohol, one carbon, one hydroxyl group, also referred to as wood alcohol. So all alcohols are inebriating to some extent. And actually the amount of inebriation depends upon the molecular weight or the size of the molecule. And methanol is the lightest, hence the title of the talk. So it has the least CNS depression of all the alcohols. However, it is still clinically significant. So methanol, as I said, also called wood alcohol or wood spirit, also historically has been referred to as Colombian spirit or Eagle spirit or Manhattan spirit. It's a colorless, flammable alcohol. Pure methanol has this generally faint, sweet odor, and crude methanol has a very pungent odor that is kind of hard to differentiate from ethanol. So just relying on your sense of smell is not going to be enough to differentiate between ethanol and methanol. It was actually a component of embalming fluid that was used in ancient Egypt. It was first isolated in 1661 by Robert Boyle. Boyle, you may remember back from your general chemistry days, is a famous chemist, but he distilled it from boxwood and named it spirit of the box. Methanol's structure was eventually determined in 1834 by two scientists, Dumas and Pelago. Pelago is pictured there on the right. But they coined the term methylene, actually from their Greek roots for wood wine. So methanol today, its industrial production began in 1923. It's mostly used today for synthesis of other chemicals. In the public, you may encounter it in various different products, mostly having to do with some sort of mechanics. So you'll find it in model airplane or car fuel. You'll find it in windshield washer fluid, actually. You'll find it in solid cooking fuel, so the small camping fuel tins that you can purchase at the outdoor store. It's contained in photocopying fluid. It's in a lot of colognes and perfumes, again, because it's a good diluent. It's found in dry gas, which is typically put in various engines, such as lawnmowers, in the winter to prevent any freezing in any of the machinery in the engines. And it's also found in what we call denatured alcohol, which a lot of times is used as paint thinner or paint stripper. So methanol is also commonly encountered in the moonshining industry. So it's a volatile alcohol. So when distilling alcohols in a pot still, it's actually the first one, or one of the first ones to vaporize off and then be collected. So actually when you're distilling your alcohol, it's recommended that you throw out the first cut as this is likely to contain a pretty high concentration of methanol. If it's not, as we'll come to find out, could potentially lead to methanol toxicity unbeknownst to the drinker. This isn't only a problem with moonshining, but also a problem with production of all illicit alcohols. It's particularly become a problem in jails where inmates tend to ferment different things on their own. And then without distillation, obviously, is a good chance that there is methanol to be contained in the illicit alcohol, likely leading to toxicity that we'll talk about later in the presentation. So historically, most reported poisonings in the United States involve the ingestion of the products that I mentioned before. Actually, a great deal of them, about 60%, involve ingestion of windshield washer fluid. I've actually personally dealt with a couple cases of windshield washer fluid ingestion in the brief time that I've been here. Cologne and perfume ingestions are actually more common in Europe and Asia. So you'll see a lot of cases in other countries of methanol toxicity from people ingesting cologne and perfume. And mass methanol poisonings have occurred, throughout history, and most commonly due historically to tainted fermented beverages that I spoke briefly about. Typically occurs in populations where ethanol is unavailable, or alcoholics who have to rely on other sources to fulfill their dependence. But actually, the first description of methanol toxicity itself in medical literature appeared back in 1855 by McFarland. So one of the earliest case series of methanol toxicity or mass exposures actually came from Atlanta in a paper published out of Grady Hospital, which I actually did not know until I was developing this talk. So pretty cool. It was back in the 50s. There was a mass methanol outbreak in Atlanta due to illegal contraband whiskey. So about 90 gallons were distributed. And when tested, it showed about 35 to 50% methanol. So actually 323 patients were affected through a 5-day period in October of 1951. There were 41 deaths that occurred. 22 of these people exposed were unfortunately dead on scene or within 30 minutes of arriving to the hospital. And then another 19 unfortunately passed away after prolonged hospital stays. But this paper is actually pretty important because it's the first characterization of the latent period that can be typical of methanol toxicity. And that's kind of the period where there's a slight delay from inebriation to the development of severe symptoms. They found typically to be 12 to 24 hours. And then they talk about a bunch of different treatments. As you can imagine, they had little experience with treating methanol toxicity at that point. So they were doing a lot of things that we would not consider today. But they did utilize bicarbonate for the acidosis, which is not unreasonable to do today. But one of the interesting things that they were doing were daily lumbar punctures on some of the patients, trying to drain the cerebrospinal fluid, which we'll come to find out is one of the major targets for methanol toxicity in the body. But again, today we would never consider doing daily LPs on our methanol patients. So another pretty important case series a little later on in history was a smaller case series of 18 patients in Kentucky in the 1960s. 8, unfortunately, who passed away. It was in a poorer area of Kentucky where they create a drink called Heads. And this was typically made from diluting shellac thinner, which typically has a high ethanol content and contains methanol, but to a low extent. So when they dilute it down, normally shouldn't be a problem. However, on this particular scenario, they used a product called Thinzol, which contains 74% methanol. And then when diluted, when they tested this product, it actually contained up to 37% methanol. So several of these patients came in with methanol concentrations well over 200 milligrams per deciliter, and we will come to find out that that's a pretty high level, and one where we would consider some pretty significant interventions. But this paper is important because this is one of the earliest documentations of dialysis as a useful tool in the treatment of methanol toxicity. Interestingly enough, most of the patients receive peritoneal dialysis, which, as we know today, is one of the less common modalities of dialysis. Typically, we do intermittent hemodialysis these days for toxicities. But nevertheless, they were able to show that dialyzing these patients did increase the rate of removal of methanol. So very important historical paper. So one of the more recent methanol outbreaks in literature happened in Iran. And this was a pretty recently published paper back in 2015. The outbreak occurred in 2013, and this is one of the more large outbreaks in literature. This was due, again, to a tainted alcohol beverage, and all of which was homemade due to ethanol being scarcely available in Iran, probably due to government and cultural reasons in combination. However, this affected over 690 patients in Iran. But in recent history, we've gotten much better at treating these toxicities, and only 8 people died. 65 patients had visual disturbances, which we'll come to find out is very characteristic of methanol toxicity. But the reason this paper is kind of important is it highlights the importance of a national surveillance system. A lot of these cases were identified very quickly due to a system that Iran had actually implemented after a very large earthquake had happened. So a lot of these cases were being identified, and the government was able to identify that a lot of these patients were being affected by methanol toxicity. They were able to implement a national protocol and distribute this across the country. And we're able to guide providers with limited resources on how to manage all of these patients. This is a system not too different than what our own FDA does here in America. So FDA has a surveillance system, and then more specifically to toxins, the AAPCC surveys for potential mass outbreaks having to do with toxins throughout the United States. So, which leads me to speak about the, I guess, infamous at this point, FDA recall of hand sanitizer. So as I mentioned, in this COVID climate, we are all very aware that we were using hand sanitizer at a increasingly almost exponentially higher rate than in previous years. A lot of hand sanitizer shortages came about, so a lot of companies started ramping up production. The original FDA notification came down on June 19th of this year. Originally included 9 hand sanitizer products by a company called Esc Biochem S.A. de CV in Mexico, and again recalled due to the possibility of methanol contamination. When they actually tested these products, one product contained 81% methanol and no ethyl alcohol, which on the package label was supposed to be 70% ethyl alcohol. And then another product contained up to 28% methanol. So this list has since been growing, and the current list of recalls is up to 215 from manufacturers all over the United States, obviously in Mexico, but also in China, and some Central American countries, and even some countries in Europe. But very important, if you or one of your patients is concerned that they were potentially exposed to a methanol containing hand sanitizer product, for sure, the best thing to do is to obtain the name of the product, the lot number of the product, the NDC, if applicable, of the product, And you can go onto this website by just Googling FDA hand sanitizer recall. We'll bring you a link directly to the site. We'll bring you to the list of products, and you can check the product against this ever-growing list to see if it could potentially be a methanol-containing product. And of course, if there's any concerns or questions, don't hesitate to call us at the Poison Center, 1-800-222-1222. So as you can imagine, the national data suggests that hand sanitizer cases or exposures have certainly been on the rise. So this is data from the National Poison Data System, or NPDS. And it shows that nationally there's almost double the amount of hand sanitizer cases through October of this year as there was last year. About 74% more, to be precise. Majority occurring in children, as you can expect, ages 0 through 5. Equal amounts male and female. But as you can see, there's that pretty significant spike when the COVID cases really started ramping up over the summer. And then, of course, with quarantine going on and everyone being at home, children having more access to these things definitely would contribute to the increase in cases. These are the outcomes with the national cases. So with NPDS data, this comes from all of the 54 poison centers across the country submitting their data to the national system. These outcomes are how we kind of characterize the outcomes of the cases. A lot of the cases aren't, a specific outcome is not known, and we also like to protect patient information. Therefore, outcomes are categorized, as you can see, as death, a major effect, a moderate effect, minor effect, no effect, not followed because it was judged as non-toxic, not followed because minimal clinical effects are possible, and sometimes we're just unable to follow, but could be potentially toxic. So as you can see, although cases have certainly been on the rise, majority do not result in death or even major effects. We're talking 3% of each total. And even the cases where it could be potentially toxic that we were unable to follow only adds another 3%. So majority of these cases, fortunately, are pretty benign and do not result in significant negative outcomes. So a little more Georgia Poison Center specific. Thus far in 2020, we've seen a greater than 80% increase in cases every month since June, and a 36.9% increase in hand sanitizer ingestions. Again, majority of these cases are in children, 0 to 5 years old. 81% of cases have been managed outside of a healthcare facility. And there's been no increase in the proportion of patients that have been treated in a healthcare facility. So 80% is typically, even with all exposures, the number, the proportion of patients that we would keep home to begin with. So this suggests that there hasn't been, luckily, really an increase in patients who have really been symptomatic or patients who are at risk for significant toxicity. Again, this data that I've spoken about thus far is just specific to hand sanitizers in general. It's very hard to code all specific hand sanitizers and collect that data. So for instance, if someone is exposed to Purell hand sanitizer, this may be coded just as a hand sanitizer in general. So it's hard to identify exactly how many of these cases could potentially have been methanol exposures. But again, this is just to be aware, this is hand sanitizer exposures in general. We are trying to look into and tease out the methanol exposures due to the hand sanitizers. But this data thus far is unavailable from GPC. However, a MWMR, or morbidity mortality weekly report, which is a series prepared by the CDC to relay timely public health information and recommendations, came out back in August. And this was a report of 15 cases of exposure to methanol containing hand sanitizer, specifically in Arizona and New Mexico through their poison centers in May and June of this year. So all of them were ingestions. Majority of them were male, average age of 43. The blood levels of these patients range from 21 milligrams per deciliter, which is right on the borderline of where we would consider potentially toxic, all the way up to above 500 milligrams per deciliter, which is generally going to be lethal without any significant intervention. 6 of the patients had seizures, which is typical of pretty severe toxicity, CNS toxicity. All the patients were blocked with 4-MP, which I will talk about a little later in the presentation. 9 of these patients were dialyzed. Unfortunately, 4 of the patients ended up passing away, and 3 of the patients ended up with permanent visual impairment, again, which I will talk about a little later on. But this is the most recent report of patients actually being exposed to these methanol-containing products. And this is one of the reasons that started the investigation into the tainted hand sanitizers and ultimately leading to this large FDA recall. So now let's switch gears a little bit and talk about methanol exposure in general. So as I alluded to, there are a few different ways to which individuals can be exposed to methanol. By and large, the most common and most potential for toxicity is oral ingestion. However, patients can also absorb methanol via inhalational route and via transdermal route. Toxicity via inhalation route is typically uncommon and generally only will happen after a prolonged exposure, and typically only occurs in people who are working in industry, specifically electronics industry can be common, and then people who are intentional abusers or huffers, as we commonly refer to. So these are patients who inhale vapors with the intent of becoming mentally altered or achieving a high. And patients who use carburetor cleaner as their modality to get high can develop methanol toxicity via the inhalation route. But again, typically this requires prolonged exposure, multiple exposures over the course of several days, unless the exposure is to a high enough concentration of methanol vapor. Transdermal absorption of methanol also occurs. However, toxicity is very rare. Most of the case reports are with infants because they have a higher body surface area to body volume ratio. So they essentially can absorb more methanol compared to how large their body actually is, leading to toxicity much more quickly than obviously an adult. And then also there have been case reports of adults becoming toxic after transdermal exposure. However, this is typically, as we'll talk about, with direct application of high methanol concentration products over a course of days. So again, this kind of prolonged exposure. So inhalational and transdermal routes much more rare. The exposures that we really worry about are the oral exposures. So methanol, when ingested orally, or in all alcohols in general, are very rapidly absorbed. Peak concentrations in the blood are reached within 30 to 60 minutes. It's not entirely bioavailable, meaning the amount of drug that's absorbed compared to how much is ingested, but it's about 90%, so almost complete. The reason for this is alcohol dehydrogenase, which is one of the primary means of metabolism of alcohols in the liver, is actually also present in the stomach, so it breaks down a lot of the methanol before it's absorbed. And then also a lot of the methanol that is absorbed undergoes first-pass metabolism, and this means that it will circulate into the blood and directly to the liver and get metabolized there prior to getting distributed to the rest of the body. So that's the reason why the entire dose is not completely absorbed into the blood. Methanol distributes very well into the ocular fluids and to the cerebral spinal fluid, which is evident by the ocular toxicity and CNS findings that we'll talk about. And it follows a very similar metabolic pathway as ethanol. Its structure varies by one carbon and a couple hydrogens, so it makes sense that the same enzymes that metabolize ethanol will metabolize methanol. And typically, the minimum oral lethal dose, based on the data that we do have, is about 0.3 to 1 grams per kilogram. Or toxicity we generally worry about is when a patient has an estimated blood level of above 20 milligrams per deciliter. This is when we would consider intervention. So the inhalation route, again, methanol is very readily absorbed through the pulmonary vasculature. Exposures up to 6 hours at 200 parts per million resulted in no accumulation of methanol or its metabolites. So this speaks to the decreased incidence of toxicity with methanol. 200 parts per million is the OSHA permissible exposure limit. 300 parts per million is generally when we would see some visual changes, some headache, and some respiration changes, but much higher and prolonged, much higher concentration and prolonged exposures, we would expect toxicity, which again is very, very uncommon. Actually, interestingly enough, concentrations have been shown to be significantly elevated in passenger cars that use methanol-containing wiper fluids. But although levels have been found to be above actually the OSHA permissible limit, there have been no documented cases of human methanol poisoning with only methanol-containing wiper fluid being in the car, normally used. But intentional abuse and industrial accidents account, again, for the majority of inhalational exposures and poisonings in the literature. Transdermal absorption, again, methanol is readily absorbed through the skin, and these absorption rates have actually been quantified experimentally. So there was a study conducted in 6 male volunteers whose hands were actually immersed in methanol for 20 minutes, and the methanol concentration was directly measured to see, how much is absorbed, how much of it is excreted by these patients. But again, severe toxicity rarely occurs and is generally due to unusual circumstances. But there are case reports of fatality following several days of exposure. There was a case report of an 8-month-old who was being treated with methanol-soaked chest pulses for a cold. They were applied for 12 hours at a time on 2 consecutive nights. And that child unfortunately went on to develop significant methanol toxicity and unfortunately passed away. And there was also a case report in the literature of a 51-year-old woman who frequently massaged methanol-containing cologne on her head. Throughout the day, over the course of 3 days, she went on, unfortunately, to develop significant toxicity, and intervention was much too late. And again, she unfortunately went on to pass away. And scarily, methanol-soaked bandages are actually used in Turkey as kind of a remedy for musculoskeletal pain. So there are some reports of toxicity in the literature coming out of Turkey. So we talked about the ways they are absorbed. I won't really speak about inhalational exposure, because that would be generally impossible with methanol-containing hand sanitizer. But what if ingested orally? This is a calculation where you can estimate a potential dose needed to obtain what we would consider a level of methanol that will require intervention. So if we assume a 70 kilogram patient, the patient would have to ingest about 8.4 grams of methanol. And using this LAVAR gel, for example, which was found by the FDA to contain 81% by volume ethanol, which is about 64 grams per 100 milliliters. 13 milliliters of this gel ingested would lead to a potentially toxic serum methanol level in a 70 kilogram patient. Now, this is a very rough estimation. This assumes that the entire dose is ingested immediately and is absorbed immediately and is in systemic circulation immediately. But as you can see, it would not take too much. We're talking a little under a tablespoon could potentially be toxic. So what about transdermal absorption? Again, using the same equation, patients would have to, a 70 kilogram patient will have to absorb about 8.4 grams of methanol to become a potentially toxic level. So using the data that I spoke about a little before, the rate of absorption is about 0.192 milligrams per centimeter squared per minute. The approximate surface area of the skin on your hand is about 440 centimeters squared. So the rate of methanol absorption would be about 84 milligrams per minute. So math would suggest that the same 13 milliliters applied entirely to one hand for 10 minutes would lead to toxicity. However, this is not entirely impossible, but very, very, very unlikely. So this would assume, again, that the entire dose is immediately absorbed. It enters systemic circulation. None of it evaporated off of the hand. Your hand was completely immersed and covered at every single square millimeter. So it is extremely, extremely unlikely that someone in normal use of hand sanitizer after one or even a couple uses would lead to significant toxicity. So as you can see, this is why oral ingestion is really the one that we are concerned about. So let's dive a little into why is methanol toxic. So methanol itself is not toxic per se. Methanol alone, floating around in the body, will give you that kind of drunk feeling, but that is not really why we're concerned about it being toxic. Why we're concerned about it being toxic is how it's metabolized. So it follows the same pathway as ethanol. So it's metabolized through alcohol dehydrogenase to formaldehyde. Yes, that formaldehyde, the embalming fluid formaldehyde. But that is not even the toxic substance that we're really worried about. Formaldehyde is, again, metabolized to by aldehyde dehydrogenase to formic acid. And this is what we are concerned about. So formic acid is the acidic metabolite that will lead to toxicity, including metabolic acidosis, but this is what is going to go on and attack the mitochondria in your central nervous system for reasons that we aren't entirely sure of. It particularly likes to attack your nerves in your eye, but also can lead to additional CNS toxicity at higher doses. And if left untreated, mortality can be up to 40%, as we saw in kind of some of the exposure literature that I talked about earlier. So as I alluded to, the big toxicity that really delineates methanol toxicity is the central nervous system toxicity, in particular, the ocular toxicity. So the picture on the left depicts a fundus photograph of the eye. And I am no ophthalmologist myself, but what it does show is some hyperemia and some retinal edema and some axonal swelling and venous engorgement, which are classic in acute methanol toxicity. So it really attacks the nerves and the vasculature in the eye, and that's kind of how we get these visual field deficits. On the right of your screen is a non-con CT, and this is showing those bilateral hypodensities in the frontal lobe there, involving basal ganglia and the subcortical white matter of both frontal lobes. So this patient likely had an extremely high methanol exposure leading to central nervous system toxicity outside of the ocular toxicity. So again, methanol toxic metabolite is formic acid, which preferentially attacks the retinal nerves, but also can lead to other CNS toxicity as well. So when we talk about toxins, and when I'm teaching junior toxicologist rotators, one of the things we talk about with the toxin is the organ systems affected and the symptoms expected. So as you can see, several organ systems affected with methanol. Big one is going to be the CNS. You're going to get that inebriation, which, yes, is the least of all the alcohols, but still significant. Central nervous system depression, altered mental status. We can see some seizures, and we can progress to a coma. And then this classic snowfield blindness, which is indicative of that retinal toxicity. We also get some metabolic derangements. So an anion gap metabolic acidosis will be seen due to the buildup of formic acid in your body, but also that buildup of lactic acid as well. And we can also see some hypoglycemia. This is generally due to a shift in metabolism, and this is typical of all alcohols in general. But this will inhibit our ability to mobilize stored glucose. And then that combined with low PO intake of glucose is generally what can cause the hypoglycemia. Then we have effects on the GI system. So all alcohols are going to cause direct irritation, nausea, and vomiting. Methanol, no different. And then pulmonary-wise, again, typical of all alcohols, in addition to methanol, you're going to get that respiratory depression. And again, this is secondary to the CNS effects. So again, this retinal toxicity that is very typical of methanol is related to the formation of formic acid. As I alluded to, it inhibits the mitochondrial transport chain and optic nerves in the retina. This anaerobic glycolysis and lactic acidosis results in a formation of free radicals, and these are kind of what attacks the nerves and can cause some demyelination and just very bad toxicity. And this toxicity to the nerves can actually continue to progress over 2 years, has been documented in the literature. Generally, it's considered irreversible. Minor visual field changes may resolve based on some retrospective analysis, but if these patients devolve to blindness and are severe enough, this generally will not be reversible. And interestingly enough, oftentimes these vision changes or the snowfield blindness is asymmetrical, so can definitely sometimes affect patients in only one side. So the timeline of methanol toxicity generally follows kind of 2 phases. In the first 12 hours is sort of the inebriation phase. You're going to see that central nervous system depression, altered mental status, an elevated osmolar gap, which is kind of measured and indicates that there is a substance in the blood that we do not typically measure. This can be pretty indicative of a toxic alcohol because we can actually measure the other components when we calculate serum osmolarity, those being sodium, glucose, BUN, and ethanol. We can measure all of those. But if we measure all of those and calculate a serum osmolarity, and then we measure the serum osmolarity and compare the two, if there's a gap, typically, into the 30s or the 40s, this can be pretty specific for ingestion of a toxic alcohol. And then early, there's going to be a minimal anion gap, which will be shown on your chemistries that you can see in your electronic medical record. There would be early on a minimal anion gap, if any, because those acidic products haven't appeared yet, and it's generally the methanol floating around in your bloodstream and hasn't yet been metabolized to those acidic end products. But as time goes on, typically 12 hours plus, can be delayed up to 24 hours. You're going to see a worsening acidosis, elevated anion gap due to the buildup of that formic acid, due to the buildup of that lactic acid, and the beginning of end organ damage. So, those visual field changes, those signs of CNS toxicity, potentially seizures, that's going to develop, after the 12 to 24 hours. So the general management of toxicologic exposures that we follow are these 6 steps that we see here: ABCs, discontinue the exposure, external decontamination, internal decontamination, labs and monitoring, and treatments. So, if you call our center and talk to one of our spies or even some of our fellows, this is generally how we're going to make our recommendations. We're going to follow this order. So specifically with methanol, obviously in any toxicological exposure, ABCs are very important. So this is obviously the initial stabilization of the patient. Big thing with methanol is going to be, ensuring that the patient is protecting their airway, make sure they have adequate ventilation, and then of course, obtain vitals, make sure they're hemodynamically stable. Next would be discontinue the exposure. And it sounds odd enough, but this can be particularly important in our patients with intentional ingestions. I have personally spoken to different attendings that I've learned from throughout my career thus far, and have heard stories of patients who have ingested alcohols intentionally and have, then went on to ingest the hand sanitizer in the room. So obviously a patient who is potentially toxic with any alcohol or even methanol, we don't want to add to that toxicity by allowing them to ingest additional hand sanitizer. So it is not unreasonable to remove the hand sanitizer from the room, in particular the patients who have had intentional ingestions. As far as external decontamination, this can definitely be appropriate. Maybe less so for patients exposed to methanol-containing hand sanitizer products, as we talked about. Minimal risk of toxicity. However, patients who have an industrial exposure to methanol definitely going to want to remove any contaminated clothing, wash the exposed area with soap and water for 10 to 15 minutes. So internal decontamination, typically something we strive to do early to prevent absorption of any xenobiotics, but in the case of methanol, we do not. So methanol is definitely too rapidly absorbed, and additionally, the molecule itself is just too small to bind to activated charcoal. And a lot of times these patients will be altered. So definitely not appropriate to administer any activated charcoal. Definitely not appropriate to consider whole bowel irrigation, as all the methanol is going to be ingested and absorbed very quickly. So whole boweling these patients is not going to be able to get any significant amount out. In a very specific scenario, in which case a patient potentially ingested a large dose of methanol immediately prior to arriving to your emergency department, you could potentially consider aspirating or lavaging stomach contents, but in general, again, not something we're going to be recommending. Some labs that you might want to be familiar with and monitoring parameters that we will be recommending, obviously vitals. Again, most tox patients are going to get an EKG. Definitely a point of care glucose, because these patients are likely going to be altered. So definitely want to rule out hypoglycemia as a cause. Going to want to get a CMP. And this is very important, definitely something you should be familiar with when we're dealing with toxic alcohols and methanol, obviously. Um, when we recommend getting serum osms, they must be on the same draw as the CMP. So this is very important. That is the only way we can get an accurate estimate of the osm gap. So very important that osms are drawn at the same time as the CMP. And when we're trending them, each osm has to be drawn with another CMP to be able to calculate the osms and then get the actual serum osms. Again, patients likely to be acidotic, so blood gas is appropriate, lactate is going to be appropriate. Volatile alcohol panel, including an ethylene glycol level if it's an unknown ingestion. If we know it's specifically methanol, we would likely only need a volatile alcohol panel, but these are going to be send-outs, not something that's really going to be affecting our management up front, but just something you need to be familiar with that we might recommend. And then co-ingestants, if it's an intentional exposure, any intentional exposure, we'll get a acetaminophen level, salicylate level, and an ethanol. So treatment, definitely important is going to be supportive care. We'll generally recommend IV fluids for hydration and or hypotension. Definitely going to want to optimize the electrolytes for any substantial GI losses. Any seizures, we will recommend treating with any benzodiazepines, whichever you're most comfortable with. Obviously dextrose if any hypoglycemia. So good supportive care is going to be very important with these patients. And then how we were going to specifically attack methanol itself is by attacking its metabolism. So the first thing you might hear us recommend, although it's fallen out of favor in recent years, potentially to the advent of fomepizole, which I'll talk about in a minute, but classically we would recommend high doses of folic acid or folate. So its mechanism is to enhance actually the elimination of the formic acid. Formic acid will be going back and forth between formic acid and formate in the serum. It's not an enzymatic conversion, it's just a chemical conversion, getting protonated and deprotonated. But when it's in formate, it's actually eliminated by an enzyme, which I won't bore you with the name of, but it is eliminated to carbon dioxide, which is blown off, and water. So we will give high doses, about 1 to 2 mg per kg IV every 4 to 6 hours for the first 24 hours to try to enhance that elimination. Adverse effects, extremely minimal. There are case reports with high doses of intravenous leucovorin, which is an activated form of folic acid. Cases of hypercalcemia because there's high calcium content in there. But again, extremely rare, very tolerated. Fallen out of favor recently, but you may hear us recommend that. Next, we'll talk about blocking these patients. So the first block that we can use is actually ethanol itself. And ethanol is a competitive substrate of alcohol dehydrogenase. So it's actually preferred 4-to-1 over methanol. So what we can do is actually give doses of methanol, ethanol, to essentially kick off the methanol from the alcohol dehydrogenase and prevent the metabolism into those toxic metabolites. So the dose is going to generally be 50% ethanol. Yes, most hospitals stock a whiskey, so it's going to be about 2 milliliters per kilogram load, followed by 20 milliliters per hour. You're going to be obtaining ethanol concentrations every hour. You're going to titrate to a level of 100 to 150. That's the level where ethanol is going to completely saturate alcohol dehydrogenase and not allow methanol to be metabolized. And then very important, if you are using this modality and we're going to dialyze these patients, the dose of the alcohol is likely going to need to be doubled because we will dialyze out ethanol on top of methanol. Adverse effects, as you imagine, patients are going to be drunk, but you can get some hypotension, respiratory depression, CNS depression. You're going to have an inebriated patient in your ICU. Patients could be hypoglycemic, could be hyponatremic. You get some pancreatitis, and also some gastritis. This method would seem cost effective because you're not administering a medication. However, going to require 1-to-1 nursing in the ICU. These patients are going to be very hard to manage. They're going to require a sitter. It's just not very pharmaceutically elegant. However, it is still used today in rural areas where they do not have fomepizole, which I'll talk about in a moment. But it is definitely still used today to block these patients early and get them to definitive care at a facility that has dialysis and fomepizole and these other things that are more common. And interestingly enough, when you block the metabolism of methanol isn't, the molecule itself is not substantially renally excreted normally by your body. It's typically blown off as vapor in the air. So the elimination half-life of methanol in a blocked patient is actually going to be about 52 hours or longer, depending on how high the methanol concentration is. So when you're using ethanol and blocking these patients and only ethanol, you're going to have a drunk patient for a very long time. So this is why we use the more pharmaceutically elegant block, fomepizole, also known as antizol or 4-MP. This is a direct competitive inhibitor of alcohol dehydrogenase, so you're directly blocking the enzyme. The dose is typically a 15 milligram per kilogram IV times 1 load over 30 minutes. That is going to subsequently be followed by 10 milligrams per kilogram every 12 hours for 4 doses. If we are continuing the fomepizole beyond those 4 doses, which is typically 48 hours, very important, the dose is going to be needed to be increased back to 15 milligrams per kilogram every 12 hours. And this is just due to the induction of its own metabolism. So it's very important after the 4th maintenance dose, we go back to the 15 milligrams per kilogram every 12 hours. Again, another adjustment in dialysis. The frequency will be changed to every 4 hours, so we're going to need to give it more often in dialysis. So very important dose change there. So some adverse effects. It's very well tolerated, obviously much more well tolerated than getting patients drunk. You're going to have some moderate nausea, some dizziness, but typically that could be just due to the methanol itself. Fomepizole, very, very safe, well-tolerated medication. Much more expensive than ethanol, but much more elegant. These patients can actually be managed on the floor. Doesn't even require an ICU bed. It's pregnancy category C, which means there really isn't much data, but if for whatever reason you do have a pregnant patient, the benefits of giving this medication far outweigh the risk of the medication itself. The risk of methanol toxicity, not only to the mother, but to the fetus, is substantial. So do not hesitate to give this medication to a pregnant patient. And then the last treatment that we'll talk about is dialysis. So this is actually enhancing the elimination of the methanol and the toxic metabolites itself. So X-Strip is actually a conglomerate of nephrologists who are also toxicologists who comb the literature that is available and make recommendations on when to dialyze toxins out. There are recommendations for many different toxins thus far, but they do have guidelines for methanol. Some of the indications for dialysis that they recommend are patients obviously who have coma, seizure, new vision deficits. Those would indicate severe toxicity. Patients who are severely acidotic, so pH less than or equal to 7.15. Or if they have a persistent metabolic acidosis despite giving them fomepizole. Patients with an elevated anion gap over 24, that would indicate late presenting toxicity. So definitely we'll want to get that out immediately. But you can see methanol concentration alone in the absence of significant symptoms. So if the concentration is over 700 milligrams per deciliter with fomepizole, or over 600 milligrams per deciliter with ethanol, or over 500 milligrams per deciliter not blocked without symptoms, that's when we would consider dialyzing these patients. So pretty high concentrations are needed with blocking to be able to recommend dialysis, where it's really going to have a benefit. If these patients get fomepizole very early, they do extremely well. And then they also recommend the presence of an osmolar gap in the absence of the methanol concentration, in which you're generally not going to have the methanol concentration available to guide your management. But you can do some back calculations with the osmolar gap, kind of similar to what I showed earlier, and kind of estimate what that level actually is. And then again, patients with impaired kidney function likely would get dialysis anyway if they had any toxin, but impaired kidney function in the presence of methanol toxicity, again, would be an indication for dialysis. Preferred modality is intermittent hemodialysis as pictured, but CRRT for our ICU nurses is also reasonable. And we would dialyze until serum methanol concentrations would be under 200 with clinical improvement. So I know I went through a lot of information. I kind of went a little over time, but the big takeaways that I want you guys to come away with from this presentation with are majority of exposures to methanol are going to be due to ingestion of mechanical products. Yes, we do have an increase in methanol exposures due to these hand sanitizers, but luckily, since the FDA recall, those exposures are likely pretty low at this point in time. Not to say that they aren't still out there, but pretty low caseload of those now that we have the awareness out there. Ingestion is likely a dangerous exposure, but inhalation and transdermal exposure under typical circumstances can also cause toxicity. I spoke about that FDA website. If you have any concerns on your hand sanitizer or your patient's hand sanitizer, definitely check that website for the most recent updated list. Yes, hand sanitizer exposures have definitely increased in the setting of COVID-19. That is unlikely to change. However, like I said, thanks to the recall, exposure to methanol-containing hand sanitizer is likely on the downturn. Methanol is definitely toxic, but it's due to its metabolite, not the parent drug itself. Treatment's going to revolve around excellent supportive care and preventing the formation of those toxic metabolites that I talked about. Dialysis may be indicated in severe cases. And then the endpoint of treatment in general, not just dialysis, but dialysis blocking, is asymptomatic and estimated or measured methanol concentration of under 20 milligrams per deciliter. All right, well, I thank you guys for your attention. I hope you found the presentation pretty interesting. I know I did, but I am also a toxicologist. But with that, I will take any questions that are in the chat box or the question box.
So we do have one question, and it's, are there any differences in methanol metabolism between men and women and various minority groups?
Good question. So the question is, are there any variation in metabolism between, men, women, and minority groups? So as I said, methanol typically, it does follow the same exact metabolic pathway as ethanol. So it would be reasonable to assume that any differences in ethanol metabolism between those populations would be similar with methanol. I'm not specifically aware of any literature investigating that. That is actually a great question and something I'll actually look into and can definitely get back to you if you provide us with your email. But what I can tell you is that actually, so chronic alcoholism actually induces metabolism of ethanol over time. So chronic alcoholics are able to metabolize alcohol at upwards of 2 to 3 times the rate of a normal human. However, that is not the case with toxic alcohols and also specifically methanol. So chronic alcoholics will not metabolize methanol any more quickly than myself or anyone else in the lay public. So there aren't any differences there as far as chronic alcoholics, but as far as differences between men, women, and different ethnic groups, like I said, it's reasonably safe to assume that any difference in ethanol metabolism between those patient populations would be the same with methanol. However, I'll get back to you on the exact numbers.
And I don't see questions, so we'll just give it a few more minutes. But I did put the evaluation link in the questions box for those of you that would like a certificate of completion or nursing credit. So if you can fill that out for us. And then if you don't see the questions box, you can send me an email as well, and I can pass those along. It's boverall@georgiapoisoncenter.org. All right, so I don't see any questions, so we'll go ahead and end the presentation. Thank you all, and be on the lookout for an email with the presentation slides and the evaluation link again. So thank you.
Awesome. Thank you so much, guys.